Let's move on to the next case. I invite Dr. Rajwinder.
It's running.
By then she starts off the case. Sunny has a comment.
It's I think.
So the new pathophysiology for CSC is venous cases right now. And most of these patients also have weakened sclera on this provider. So this case is almost like a venous cases. Okay. So more like a venous cases kind of thing. So more looks like a UVL lesion overlapping because I would probably think because the exterior body is there with pain. Makes sense, I think. And if the angles are narrow, it's even more favor of. Many of the patients have shallow angles and they undergo PI. That leads to
Thanks.
Thank you, USA, for giving me the opportunity to speak in front of UV experts. Thank you. It's not moving. It's not moving. So I am grateful to my mentors. Case 1. 29-year-old female presented in IOPD 2 months back with the chief complaint of blurring of vision right eye for 3 days. And no relevant other history except the history of similar complaint in the past in left eye, for which the patient underwent treatment and recovered well. And the vision in the right was best corrected vision was 6/60. Other things were normal. And on the examination, anterior chamber showed anterior chamber cells, sclera and iris were normal, lens was phakic. So we can see here the disc edema with the multiple deep ill-defined yellowish lesions with pocket of subretinal fluid at the posterior pole, and the left eye showed the few healed lesions. Fundus autofluorescence imaging shows the hyper-autofluorescent lesion with the central hypo-autofluorescence, the 3 dots, with the hypofluorescent and the hyperfluorescent corresponding to the fluid. FFA shows the multiple choroiditis in the inferotemporal quadrant, which were hypofluorescent in the early phases and hyperfluorescent in the late phases, and along with the pooling in the area of the fluid. And there is a ballad, hyperreflective dots with ritus and elevation near the disc margin. We can see the granuloma here in the OCT. And the patient was started on the topical treatment for the right eye, prednisolone and nape of neck, and patient was asked to get back with investigations report, and decision of starting the oral steroid was to be taken. Montauk's test was read after 72 hours, highly positive. And HRCT's chest showed the tiny calcified nodule in apico-posterior segment of left upper lobe, suggestive of post-infection. Patient was offered a diagnosis of ocular tuberculosis and advised to start the anti-tubercular treatment after consulting the physician. And the treatment was started along with the steroids, and we can see that improvement in the fundus picture. And also in the OCT, the resolution of the ballad and the hyperreflective material is noted over the RPE. So the vision on the presentation was 6/60 and the OCT, and the vision improved to 6/18. So this case, as there was granuloma, but the patient didn't give any consent for the anti-VEGF in this case, and she was treated only with the anti-TB drugs and the oral steroids, and she is maintaining the good vision. Another case, choroidal tubercle to choroidal granuloma. A 14-year-old female was admitted to the pediatric intensive care unit with a complaint of altered sensorium and irritability, history of fever on her FOB since 1 month, along with the headache, nausea, and vomiting since 1 week. So the meningeal irritations, Kerning, Brudzinski sign, neck rigidity was present. On dilated fundoscopy, the multiple choroidal tubercles with the disc edema, both eyes were seen. The fundus picture has been taken with the MRI cam. So we can see in the picture the choroidal tubercles in the both eyes, and fundus picture on the fundus camera, which show papilledema with the later on the picture was taken showing the healing tubercles both eyes, except one tubercle which progressed to the choroidal granuloma. So they were advised to get the CSF cytology, ECL, and CBNet, which came out to be positive for the TB. So here is the multiple imaging of the tuberculous choroidal granuloma. The color photograph showed the granuloma with a pocket of subretinal fluid. Fundus autofluorescence imaging shows the hyperautofluorescent lesion with the central hypoautofluorescence. Near infrared reflectance revealed the hyperreflective lesion with the hyperreflective halo. So the enhanced depth imaging of the SDOCT show through the central lesion of granuloma shows the smooth choroidal elevation with the localized obscuration of the choroidal detail and secondary outer retinal disruption of the photoreceptor ellipsoid layer through the outer nuclear layer by the hyperreflective material, that is contact site, and the lobulated isoreflective choroidal lesion with loss of vascular pattern and dome-shaped elevation of the overlying retina. Three-dimension view of the choroidal granuloma with the tiny pockets of subretinal fluid at the apex of the lesion and hyperreflective infiltrate with the local disruption of the outer retina and retinal pigment epithelium was suggestive of the activity. Then the demonstrated resolution of the tubercle with treatment, restoring the normal choroidal vasculature with increased signal transmission effect was seen behind. So this patient showed the MRI brain also showed the ring enhancing lesions in the bilateral. So the treatment was started and along with the oral steroids. So these are the two cases, and as the vision was in the second case was 6/6, so they didn't give any consent for the anti-VEGF. So both the patients were treated with the anti-TB drugs and along with the steroids. Thank you.
Thanks a lot. The tale of TB continues, so it never ends. So I guess I thank everyone for having the patient hearing, and hope we transmitted enough knowledge. And the show stops now. So dear sir, thanks for very.